Hi guys, this is a review of EBM for exam 3. We're just going through this one because hopefully it's some easy points that we can pick up. But just a good reminder that we have accuracy versus precision. So good precision is good grouping, repeatableness of your data, and then accuracy is how close you are to the true value. So this is good grouping, aka good precision, but poor accuracy. And then here we have good grouping, aka good precision, and good accuracy as well as we're close to the true value of the thing we're trying to measure. All right, then we'll talk about sensitivity, specificity. But before we get there, we have stuff on prognosis, risk, and odds. So for these lectures, I just chose the things that were highlighted that said this will be on your test, and everything else I ignored. So sorry about that, but also maybe that's a good thing. So we have relative risk, and relative risk is defined as for particular events that you're studying. The example we'll get is the rate of myocardial infarctions. So rate of heart attacks in the treatment group divided by the rate in the control group. So event rate in the intervention group divided by event rate in control group is relative risk. And then relative risk reduction is 1 minus the relative risk. And then finally, you have absolute risk reduction, and this is just a subtraction value. So event rate in the intervention group minus the event rate in the control group. That's absolute risk reduction, ARR. And then we have number needed to treat is 1 divided by the absolute risk reduction. So we are told that the relative risk reduction is often more impressive than absolute risk. The lower the event rate in the control group, the larger the difference between the relative risk reduction and the absolute risk reduction. All right, so relative risk reduction is more impressive than absolute risk. But remember, relative risk is just the ratio of the event rate in the intervention group. So how many of our treatment group had a heart attack divided by the event rate in the control group, how many people in the control group had a heart attack. And then relative risk reduction is 1 minus the relative risk. All right, so let's just go with that example. We have a new drug that's come out that claims it decreases the rate of heart attacks for patients. So this is our events right here, heart attacks. By 50%. Okay, cool. We don't really care about that number, though. A group of 2,000 women ages 30 to 35 who are non-smokers and have no other medical problems are randomized to receive this new drug and then have been followed for 6 months. So we have a control group, no drug, and we have a treatment group, drug. So calculate relative risk reduction. Well, relative risk reduction is equal to 1 minus relative risk, and relative risk is equal to the sort of event occurrence in the treatment group. So event rate in treatment divided by event rate in control. And so this is our treatment group, 1 over 1,000 divided by 2 over 1,000. And so that ends up being 0.5. So our relative risk is 0.5. And so our relative risk reduction is 1 minus 0.5 or 50%. Okay, absolute risk reduction is our event rate in the intervention group minus the event rate in the control group. So absolute risk reduction is equal to event rate in the treatment group, so 1 over 1,000 minus the event rate in our control group, 2 over 1,000, and that's equal to a very tiny number. We're going to use our calculator here. So 1 divided by 1,000 minus 2 divided by 1,000, and so 1 divided by 1,000 minus 2 divided by 1,000, and we get negative 0.001. That's just saying that there is a decrease in relative risk reduction, or absolute risk reduction is 0.001, but you multiply that by 100, so you get 0.1%. Okay, calculate the number needed to treat. So that's equal 1 divided by absolute relative risk. So we do 1 divided by 0.001, and that is equal to 1,000. So you need to treat 1,000 patients to prevent 1 myocardial infarction, 1 heart attack. All right, so not too bad. Relative risk is event rate in treatment group divided by event rate in control group. Absolute risk reduction is event rate in treatment minus event rate in control. And then need to treat to have an effect is 1 minus absolute risk reduction, just the pure value, not the percentage. Okay, so here's just another example. A group of 2,000 men aged 60 to 75 with hypertension, hyperlipidemia are randomized to receive a new drug, and then followed. Here's our results. So relative risk reduction is 1 minus relative risk. We know relative risk is equal to the event rate of the control group divided by the event rate of the treatment group divided by the event rate of the control group. And so we have same thing. This ends up being 1 over 2, so 50%. And then absolute risk reduction is equal to the treatment event rate in the treatment group minus the event rate in the control group. So it's 30 over 1,000 minus 60 over 1,000, and you get 30 divided by 1,000 minus 60 divided by 1,000. Okay, and we get 0.03. And then need to treat to have an effect is 1 divided by absolute risk reduction. So 1 divided by 0.03, and that ends up being 33.3 people. All right, so you need to treat 33.3 people to have one sort of positive effect, which presumably this is stopping some sort of the same thing, heart attack, presumably. All right, so risk ratio. We talked about relative risk. Here's an annoying thing. We have risk ratio, which is annoying because it's the same thing as relative risk, but we are given a table instead. So we have risk ratio is a measure comparing probabilities in 2 groups. It's also known as risk ratio. So relative risk is also known as risk ratio. The relative risk is simply the ratio of 2 conditional probabilities, which we're familiar with as the event in the treatment group divided by the event rate in the control group. So a risk ratio of 1 implies the event is equally probable in both groups. A risk ratio greater than 1 implies the event is more likely in the first group, and then a risk ratio less than 1 implies the event is less likely in the first group. All right, so we are given this formula, but you should just think if you're talking about heart attacks, right? So you have your treatment. This is your treatment group event rate, and this is your control group event rate. Right, so let's just put it in action. I think that'll make the equation make more sense. So here we have some people getting COVID versus not getting COVID, and we have 2 populations. This is our sort of quote-unquote treatment group, which isn't really a treatment group, it's just people who went to church, and this is our control group. Okay, so relative risk is the number of, it is the event rate in the treatment group, I call it TG, divided by event rate control group. And so for the event rate in the treatment group, well, we had 15 people went out and got COVID, and 15 people went out and didn't get COVID, so you have 15 with COVID divided by 15 plus 15. Okay, so that's the event rate of the treatment group, divided by the event rate in the non-treatment group. So we had 5 people with COVID, but there were a total of 65 plus 5 people who were in the control group. So the risk ratio of getting COVID if you went to church versus not going to church, well, let's find out. So we have 15 divided by 30 over 5 divided by 70, and so we have 0.5 divided by 5 divided by 70, and so we have 7. So you're 7 times your risk is 7 times greater if you went to church overall. So risk ratio, it's more likely if you went to church you would get COVID because you're greater than 1. All right, so then here we just have another example. Calculate the risk ratio, also called relative risk. So here's group 1, here's group 2. In the interest of time, I'll let you guys solve that on your own. But again, just plug in 15 people, 285 plus 15 over 5 over 695 plus 5. It's not so bad. Okay. All right. Then we have something called odds ratio. And so odds ratio is new to us. It's the way of comparing whether the probability of a certain event is the same for both groups. And so basically, this is dealing with the case where we don't know the total population. So basically, an odds ratio of 1 implies the event is equally likely in both groups. An odds ratio of greater than 1 implies the event is more likely for the first group. And an odds event less than 1 implies the event is less likely for the first group. So this is used in case control studies because the total denominator for the entire population is unknown. We don't know the total number of people. All right, and so that is a little bit confusing, but here we were saying we had the assumption that we had a total of 15 plus 15 people, so 30 people who went to church. Here we're saying, well, I know that 15 people went to church and got COVID, and I also know that 15 people went to church and didn't get COVID, but I also don't know, how many, like maybe there's like more to this population. We don't know the totals per se. So risk ratio or odds ratio is simply the ratio of went to church and got COVID over went to church didn't get COVID. So it would be odds ratio of 15 over 15 divided by stayed home didn't get COVID versus or stayed home got COVID over stayed home didn't get COVID. So this is just the event rate in this population over event rate in this population. But again, here we're making the assumption when we're doing risk ratio that this is the total population, whereas odds ratio is just comparison of the odds in each row. So this would be 1 over 5 over 65. So 5 divided by 65, 1 divided by, our answer is equal to 13. Okay, so then this one is 5 over the odds ratio here, 5 over 285 divided by 5 over 695, and you guys can solve that. All right, so moving on, this is a little bit more of the conceptually challenging part, but diagnostic tests, we categorize them, or the way that we describe them, we have sensitivity and specificity. So sensitivity is the proportion of positive tests, so this is to describe tests, right? Proportion of positive tests that exist among people who are diseased. So if you have a sensitive test, then it is showing that ideally, if the person is diseased, then they should show up as positive, right? So the equation for this is the number of true positives divided by the number of true positives plus false negatives. So basically, the number of people who have a disease, who tested as having a disease, divided by the total number of people who have the disease. And so we remember this with SN out, so snout. A test with high sensitivity, if negative, rules disease out. All right, so S snout, a sensitivity test, a test with high sensitivity, if negative, rules disease out. SN out, snout. All right, so here we have an example. We have 143 POCUS exams are included in final analysis. There are 41 fractures diagnosed and 4 false negatives. There are 4 false positives overall. So what is the sensitivity of this test? All right, well, sensitivity, again, is proportion of positive tests among the disease. So sensitivity is equal to the number of true positives divided by the number of people with the disease, so number of true positives plus the number of false negatives. All right, so sensitivity is about positive. Therefore, being sensitive is a positive attribute. That's how we can remember it. So here we have the POCUS test, and that came up positive for 35 people who did in fact have a fracture. So, or 37. So right now we have 37 over 37 plus, and then the number of false negatives. So here's negative, here's 4. So this would be false negative because they did in fact have a fracture. So our sensitivity is 37 over 41, and that is 90.2%. Okay, and so high sensitivity, S snout, if negative, rules disease out. Okay, so great, let's move on. Then we have specificity, and so specificity is the proportion of negative tests that are among the non-diseased. So specificity is checking if the negative tests are good. And so our equation for this is true negatives divided by the true negatives plus false positives. So the number of people who tested negative, who are actually negative, divided by the number of people overall who are without disease negative. All right. So S spin, a test with high specificity, if positive, rules disease in. Okay, S spin. So we have SN out, SN sensitivity, if negative, rules disease out, and then we have S spin. Specificity, if positive, rules disease in. All right, and then specificity, we said, is the number of true negatives divided by number of true negatives plus false positives. And so here we have true negative, no fracture, and came up negative on the POCUS exam, so that's 98, divided by true negative plus false positive. And so here we have positive but no fracture, so that would be 4. So we have 98 over 102. as our specificity. So we have SN out, SP in. Specificity, proportion of negative tests among the non-disease. SN out is proportion of positive tests among the disease. So specificity, non-disease, negative tests, and our sensitivity, portion of positive tests among the diseased. Then we have our final concept, which is likelihood ratio, and it is the likelihood of a particular result among the diseased as opposed to among the non-diseased. And so likelihood ratio, portion of those with the disease who have a positive result divided by proportion of those with the disease who have a positive result. So likelihood of particular result among the disease as opposed to among the non-disease. But our equation for this is just likelihood ratio is equal to sensitivity divided by 1 minus the specificity. Okay, so here we had our sensitivity was 37/41, and then our specificity was 98/102, and then you could calculate that overall. But again, likelihood ratio, likelihood of a particular result among the disease as opposed to among the non-disease. And the other way of saying it is proportion of those with disease who have a positive result divided by proportion of those with disease who have without disease who have a positive result. And you calculate it as sensitivity divided by 1 minus specificity. Okay, so then the final thing is we were told about ROC curves. It balances sensitivity against specificity, and it was developed by radio operators to distinguish signal from noise. With the radio receiver turned up, there's more signal, but also more noise. At each setting, the sensitivity and specificity can be measured in graph. Cool. But basically, this graph is so small that it's almost not useful. But here's 1, here's 0. 0 reflects a perfectly inaccurate test. 1 represents a perfectly accurate test, and then the area under the curve of 0.5 suggests no discrimination. Can't diagnose patients with or without the disease based on the test. So this isn't going to be on the exam from what the document I took was, or what the lecture note said, because the professor said highlighted stuff, so I wouldn't worry about that. But then just a quick summary, we had the right test for each purpose, screening, test you want to do high sensitivity, and again, SN out, so sensitivity if negative rules disease out. So high sensitivity, making a definitive diagnosis, high specificity, SP in, spin, specificity if positive rules disease in, managing a disease process, optimal balance of sensitivity and specificity. All right, so summary. Diagnostic tests can include any maneuver intended to modify the estimated probability of diagnosis, study design, concurrent or coherent study, or cohort study, comparing the test to criterion standard for diagnosis in an independent or blind manner, and then results described as kappa for agreement. We were told we need to know that. Likelihood ratios, sensitivity, specificity, ROC curves, not going to be tested. Each of these results is an estimate based on the data, and this has a confidence interval that describes its precision. All right, so that's it. Maybe that was helpful, maybe not. I feel like, we're just doing our best, so good job, guys.